All right, so the respiratory system consists of the airway, the lungs, the diaphragm, and all the vessels that involve the process of both respiration and ventilation. So, just a quick recap: the upper airway consists of the pharynx, which you have two different sections of pharynx. You have the nasopharynx, which is this upper part here, and then you have the oropharynx, or mouth, which is the lower part here. Then you get down past the epiglottis, which prevents food from going into the trachea, and then once you get past the larynx, which is your voice box, then you get down into the trachea, which then becomes your lower airway. And the lower airway consists of the trachea, which is this area, splits off into the bronchioles, which are the right and left. These are the main stem, and then you get down into the bronchioles that split off into the lungs and eventually end up in the alveoli, where your arteries and veins meet. Remember, the alveoli are only 1 cell thick. This is where oxygen and carbon dioxide exchange themselves. So keep in mind, let's get rid of the stuff there. There are two different things that we talk about. One of them is ventilation. Ventilation is the process of moving air in and out of the lungs. That is different from respiration, where respiration is the process of exchanging oxygen and carbon dioxide. That happens, respiration happens right here at the cellular level. Remember, the carbon dioxide is dropped off in the lungs where the body can breathe it out, and oxygen is picked up inside the lungs, or inside the capillaries at the alveolar level here. So that's where respiration occurs. You also have what is called cellular respiration, which is pretty similar. The difference here is this is converting glucose into energy using the oxygen. It creates carbon dioxide and water. So this is kind of what it looks like. Glucose plus energy yields the chemical energy, and here's an overlook of this. This is just a little deeper than what you really need as an EMT, but since some of you are moving on, this will help you understand the difference between cellular respiration and just basic respiration. So when we talk about the ventilation, we're talking about getting oxygen in and out of the lungs, or more specifically, air in and out of the lungs. Does not necessarily mean that that air is being exchanged at the alveolar level. That's where we get into some of the respiratory diseases and stuff that will prevent or reduce the respiratory or the respiration cycle. And again, respiration being the exchange of oxygen and carbon dioxide here at the alveolar level. So a quick review: ventilation is the act of moving air in and out of the lungs. Respiration is the process of exchanging oxygen and carbon dioxide. That's the two primary things to keep in mind. Ventilation, getting air in and out. Respiration is where the air gets into the lungs, down into the bronchioles, and into the alveoli, and then it's split off and feeds. The oxygen is exchanged for carbon dioxide. You exhale the carbon dioxide. So under this process, ventilation is the primary thing we want to talk about right now. So we're going to talk specifically about ventilation. All right. In order to ventilate, the body has to it works off of a negative pressure. What happens is the diaphragm, this right here, it will move downward, and when it does, it creates a negative pressure inside the lungs. So by the diaphragm moving down, the lungs will start to expand and pull air in through the upper airway. It goes through the upper airway, whether it's the nasopharynx, oropharynx, and then down into the tracheals, the trachea, bronchioles, and then into the lungs. Now, where we can run into issues with ventilation, obviously, would be like an airway obstruction, where, let's say, somewhere right in here, the patient has, say they've swallowed something or inhaled something, and it gets right here and causes a blockage. Well, in that case, when that happens, they cannot get air in past that object, and that creates a significant problem. Remember, we have the ABCs: airway, breathing, circulation. You have to have those to be alive. You have to have A before you can have B, and you have to have B, A and B in order to have C. Airway, breathing, circulation. So if there is an airway problem, that is a life threat. We have to fix it then. When you find an airway problem, fix that problem. Breathing. When you find a breathing problem, we will fix that problem. And that's what we're talking about now with the respiratory system and some of the different issues that you run into. Some of the breathing problems we can start addressing by giving oxygen and worry about getting the patient loaded and transported. And then there's certain medicines we can give that'll help with that. We also can get into CPAP, which will help. So airway, breathing, and then we get into circulation. You have to have those in order for respiration to happen. You have to have enough oxygen inhaled whenever they breathe in. You have to have enough cells in the body and in the bloodstream in order to get the oxygen picked up. You also have to have the proper exchange at the cellular level for respiration to take place. So several different things that are in that. That's all part of what it takes to have respiration. You've got to have enough oxygen when you breathe in. You have to have enough room in the lungs. You've got to get all the air into the lungs and the oxygen into the lungs. There has to be proper offloading at the cellular level, and then once it gets out and into the body, you have to have proper offloading at the body level as well. So it takes all of those things in order for normal respiration to occur. Ventilation that we're talking about requires the airway to be open. It requires the air to be able to move in and out. And a term is tidal volume, the amount of air that they breathe in. There has to be adequate tidal volume, so they've got to be able to breathe in enough air so that they can fill their lungs and get the oxygen down into the alveoli. Any variation from either one of these two events, whether it's respiration or ventilation, any variation from that, anything that deviates from the norm will create problems for the patient. And that's what we get called for. So with either one of those, you can have the airways narrowing. So if we zoom in again here, you can have these airways narrowing here for various reasons, whether it's epiglottitis, that's most commonly seen in pediatrics, but it can be seen in adults as well. Epiglottitis would create swelling of the epiglottis, which could reduce the space here. You could have something with the bronchioles where they start to restrict, they narrow down. When they narrow down, then you're running into situations that will reduce the ability to move air in and out. You can have problems with the alveoli. You run into this in things like COPD, where these have a tendency to start to collapse. So it's called atelectasis. They get stiff and they don't inflate and deflate as well as they should. You will see that also in asthmatics, especially severe asthmatics, where these vessels, the bronchioles and the alveoli, start to collapse. They get really small and tight, and when that happens, you can't move enough air in and out. So in the next video, we'll talk about the signs and symptoms that we run into with any of those different situations. Something else that I didn't mention that you can run into is, for one reason or another, you can start getting fluid inside, generally inside the alveoli, different areas here in the lungs. That can come from heart failure, which would back up into cause kind of fluid to back up into the lungs. It can come from obviously drowning, which is the most what most people think when they think fluid in the lungs. But there are other reasons that you can have fluid inside the lungs. Pneumonia is one where they get infection in here. They start getting some fluids and mucus things build up, and when that happens, it causes a reduced ability to get air in and out, which is the ventilation part. And also, when these are collapsed and the vessels, there's not enough oxygen getting in here, the respiration is reduced. So then these items are not exchanging oxygen and carbon dioxide like they should. A term to keep in mind is cyanosis. Cyanosis is the bluish discoloration of the skin. You will see it in patients that are in severe distress. There are some patients that kind of are cyanotic on the regular, and those are rare cases, but you do see those from different disease processes and stuff like that. But cyanosis is definitely a sign of a respiratory problem. You will see it around the nail beds. You will see it around any capillary area like the lips, the palms of the hands, the soles of the feet, anywhere that you have a capillary area. That's generally the first place that cyanosis will start to show up. Generally, again, lips and nail beds are the most common places that you see it, and some of the first places that you see it. Again, that's cyanosis. And that is definitely a sign that there is a problem here somewhere. You don't know whether it is a ventilation problem or a respiration problem. So patients that have a tendency to be hypoxic and cyanotic regularly are generally the types that are patients that are like COPD, long-term COPD. They have the barrel chest. They are generally on home oxygen, some type of oxygen on a regular basis. And those patients are the ones that we discuss the hypoxic drive and the theory of the hypoxic drive. I've got some stuff that you guys can read about that, some videos and stuff to look at that. But here's the Kellyology on the hypoxic drive. Patients that are normally on oxygen, long-term COPD patients, people like that, their body normally is used to not having a lot of oxygen. So the theory with the hypoxic drive and shutting down the hypoxic drive is that if their body is used to not having a whole lot of oxygen, if you suddenly give them lots of oxygen, like a non-rebreather at 12-15 liters a minute, their body goes, holy crap, I've got enough oxygen here, I don't need to breathe for days. And then they just stop breathing because they're used to working off of the hypoxic drive in lieu of the normal form of ventilation. So the whole purpose of the hypoxic drive and the theory of the hypoxic drive is somebody who is normally on oxygen or who has that COPD, their pulse oximetry may normally be on the low side, talking 88, 92, somewhere in that area. So the theory is to provide them enough oxygen to titrate them to around the 92%. Be happy with 92% on them. Don't push to get them up to the 98, 99%, because in theory that the high flow oxygen will cause them to stop breathing. Now, with that being said, do not, under any circumstances, withhold oxygen from somebody who needs it. If they are struggling to breathe, if they are cyanotic and struggling to breathe, give them oxygen. The hypoxic drive, generally, in order for it to shut down, it is said that they need long-term oxygen. In my career, I have never shut a patient down. I've never seen one shut down in the little bit of time that we have them. So that doesn't mean it doesn't happen. It just ultimately to say, do not withhold oxygen from somebody who needs it. If they're struggling, give them the oxygen, and just be prepared that if you give them high flow oxygen, there is a potential that they stop breathing. And in that case, we have the bag valve mask and ventilation devices so we can assist their ventilation. So that's the hypoxic drive and the theory behind it.